When we first started working with PHN, we needed to know where they were at in order to move forward with age-friendly care. So the Institute for Healthcare Improvement has a ton of great resources and tools available. They have a guide specific to primary care practices, which we used as a starting point. We developed a survey, and it was essentially a needs assessment that we used as the main tool for PHN in order to figure out, what they were doing with each M, who was doing each M, what tools they were already using. We could provide them with more evidence-based tools and assessments that their providers could then use within practice. PHN already was doing each of the M's to some capacity. They may not have been doing every time at every visit for every older adult, but everybody focuses on all 4 M's. In regards to depression, so that's the M for mentation, they reliably, in every older adult that goes in there, they have a PHQ-2, which is a depression screener. They do depression really well. However, when we focused on mobility, which is a different M of the 4 M's, they were doing a fall risk, but they really weren't focusing on mobility. So we went in and we worked with their electronic medical record, and we were able to add a daily mobility goal. And that's something that enhances the care of every older adult and maybe not somebody just with a high fall risk. When you look at PHN right now, they are doing a phenomenal job assessing each of the M's at every single annual wellness visit that they have. They've really got each M into the electronic medical record, but they haven't stopped there. They've actually educated all of their annual wellness nurses. They're doing trainings at the beginning of each year, annual trainings that focus on age-friendly care. And now we're just continuing to build upon that, and we're going to have the 4 M's ingrained in every visit that PHN provides. So when we first started working with PHN, they're a large health system, and we knew it would be difficult to reach all of the sites at once. So we picked 3 pilot sites, and we really got to know their team, their electronic medical record, and we focused on collaboration at the beginning. We then expanded to do small tests of change while we made changes to their electronic medical records, specifically the annual wellness visit, to make sure that the assessments that we wanted them to do in regards to each M worked for them. We initially started doing education via the ECHO platform. That way we could reach multiple sites in different locations in Pennsylvania. And we expanded our reach as the years went on.
The 4 M's have made a difference in how I practice care now by making me think first what matters to the patient, and then we look at the other things like the medications, mobility. But when I look at what matters, it does change the way that I treat the patients. It doesn't always mean giving them a medication or giving them this. Sometimes it's just coming in, listening to what's going on in their life. Yeah, we used to come in, focus on hypertension, diabetes, and I didn't really do that assessment of the mobility. Just basically asked them a few questions, and now we do have them do the sit, go, see how they walk, make sure they're not falling in the home. So since doing this 4 M's, that's really helped me to focus in on their mobility too. The most challenging part of the 4 M's for me to implement was the medications. There's a lot of risk with the medications, especially in the elderly population. So usually whenever they come in, most patients think that there's a medication to help with any kind of underlying issue, and sometimes there's more risk that come along with those medications. Medications sometimes make things worse, including their mentation, their mobility. So usually whenever they come in, I talk to them about the medications, the options, and then all the side effects that could possibly come along with the medications. And then I let them determine if that's something they want to do, if they want to try a medicine or what they want to do and try to fix the problem. Now, since incorporating the 4 M's into my day-to-day workflow, Instead of going in, talking to the patient, telling them what I think's best in the treatment plan, I actually go in now and listen. We have conversations, and we do more of a collaborative agreement together. So it's not me just picking the treatment plan. It's them talking to me and telling me what they prefer and what works best. To anybody, out there caring for older adults, I always recommend to use the 4Ms, the mobility, mentation, medication, and what matters especially. Because as we get older, definitely different things change, and what matters definitely changes. So we just got to look at the whole picture and then talk to the patients and see what makes them happy.